Participant will to that also. Yes, participants. Can it be a part? Oh.
কিন্তু স্লাইড দেখতে পাচ্ছো?
না এখন দেখতে পাচ্ছি না।
তোমরা ইউটিউব ছেড়ে দাও, দরকার হলে ইসে করো।
Yeah, icons is coming. এটাকে স্লাইড শোতে যান।
হ্যাঁ দেখা যাচ্ছে স্লাইড শো।
হ্যাঁ স্লাইড শো আসছে না, আমার পুরোটা স্লাইডই আসছে লেফট সাইডে আর মাঝখানে।
রাইট, ঠিক আছে, ওয়েট।
Yeah.
Am I audible in the seminar room?
Yeah.
Okay.
হ্যাঁ দেখা যাচ্ছে, দেখা যাচ্ছে,
দেখা যাচ্ছে।
তুমি নেক্সট বলবে খালি।
আচ্ছা, thank you.
Okay.
Thank you. I'm feeling quite nostalgic to see all of your faces. I can see Dr. Apurva Ghosh sir, Kundu sir, Priyankar sir, and there was Shukanto sir as well, and Nupur madam. It's quite difficult to see who else are there. Yeah, Kundu sir, I said that. I'm really.
Yeah.
And thank you for having me to talk about epilepsy in pediatrics. I'm a consultant pediatrician with a special interest in epilepsy and a functional neurological disorder, working in Leicester. As you know, epilepsy is a very big topic. Itself, it's a subject, and it's not possible to cover epilepsy in one presentation. I have about 500 slides on epilepsy. What I have done is I've chosen some random slides to go through its overview without going into the details of each and every specifics of it. Given an opportunity, I'd be happy to talk about different types of epilepsy in later presentations. Change, please. Next. This is the first slide which shows the incidences in UK. It's quite UK specific. The number of cases are quite high here. Almost 600,000 people suffer from epilepsy with very good incidence. Almost 1 in 100 people in UK would have epilepsy, and 87 diagnosed every day. Children are not behind either. Next. Next, please. So, what is seizure? I know you all the trainees sitting behind would have the idea of what is seizure. What I find seizure as a very good definition of seizure is anything that seizes you from doing whatever you're doing is seizure, isn't it? It could be, say, a sudden change in behavior, or your heart stops, your brain doesn't get the blood, and then suddenly you lose consciousness, and that's a change in your behavior. So anything that seizes you from doing whatever you are doing is called seizure. As a neurologist, we are not interested in seizure. What we are interested in is it coming from the brain? So only when it's coming from the brain, that's when we call it epileptic seizure. Next, please. So there could be various causes of non-epileptic seizures, which doesn't arises from the electrical activity or change in the electrical activity in the brain. Next. And the next. So the epileptic seizure comes from the brain, and next question comes, what is the risk of recurrences? So we all are entitled to have one seizure in the life, even as a general population. That does not mean you would have a recurrence of seizures or recurrence of epileptic seizure. Even if we talk about epileptic seizures, we all are entitled to have it. So only when, based on your certain circumstances, when your risk of further epileptic seizure goes high, that's when we say that you have got epileptic tendency. And this risk depends on what are the precipitating factors that have precipitated your seizure in its first instance, and any abnormal neurological examination that includes your developmental trajectory, any abnormal imaging, such as you were born premature and had some PVL lesions on, or some EEG findings, or a childhood epilepsy syndrome, which has a very specific EEG finding along with presentation at certain age with certain features. Yeah, you don't need to wait for the second seizures, but even after the first one, you can say that you have got epileptic tendency and can diagnose with epilepsy. Family history, of course, is very important, as having a family history of epilepsy increases the risk of further seizure in you. Next, please. So next, no, sorry, go back, please. I had some animations that's not coming up. Anyway, leave it. So as you can see from this slide, the chances of second seizure after the first, in whatever age group you are ranging anywhere from 20 to 40%. But once you have the second seizure, the chances of third seizure and then further seizures increases drastically, anywhere from 50, 60 to 80%. And that's why this term in the definition, that why you need to wait for the second seizure when you have not got criteria to diagnose it as certain epilepsy syndrome. So why you need to wait for the second seizure. And this slide explains why we need to wait for the second seizure, because after first seizure, you may not have seizure whole of your life. So after the second seizure, the chances of having third, fourth, fifth increases by more than 60%. And that's when we diagnose it as epilepsy if the clinical description or the video evidence or the EEG suggests that you have got epileptic seizures. Next, please. So come and next again. So that brings us to the definition of epilepsy. That is a two or more unprovoked seizure occurring 24-hour apart. Would we call seizures clustering of seizure which happens within a day as epilepsy, or a first or two seizures? No, because it confers the same risk for later seizures as does the single seizures. So if they have 7, 8, 9, so a febrile seizure patients comes in with 3 seizures in a day, though you would call it as atypical, but that does not pose the increased risk of epilepsy later on in the life, because they all have happened within 24 hours. Next, please. This was the old classification of epilepsy, which has been changed. The previous classifications were partial seizures and the generalized seizures and unclassifiable seizures. Now, next. Now, the International League Against Epilepsy, they have done it in a systematic way. And what they're saying is any seizures, the first thing to know is whether it's an epileptic seizure or not. If it's a epileptic seizures based on the description or on your video evidence, then you need to find out whether it's a focal onset or a generalized onset. In most of the situation, you would not be able to find that out, because when the seizure starts, there might not be anybody to see it unless the child is under constant eyewitness of somebody either in hospital or at home. So most of the time you encounter a patient who presents with generalized seizures. You don't know how it started. It could be focal or the generalized. So after epilepsy, whether it's epileptic or not, the important thing to know is whether it's a focal onset or a generalized onset. If it's whatever the onset is, they have broadly categorized into there's a motor component available or associated with it in the movements, or it's completely non-motor. And that's when your all classification ends. So Motor could be anything. You all know it's a tonic, clonic, atonic, epileptic spasms, and non-motor involves autonomic phenomenal behavior arrest, cognitive seizures, emotional seizures, sensory seizures, things like that. So this is the one way of classifications. The another thing that comes into it is a specific childhood syndromes, where you see specific features in a certain age group with certain EEG changes, such as childhood absence epilepsy, Dravet syndrome, Lennox-Gastaut syndrome, and all those fancy epilepsies. So that's the two way to classify seizures. Next, please. In the focal seizures, depending upon which area of the brain your seizures are starting, you would have initial features that would suggest it, and that's the catch. So that's why it is very important to find out how it all started. Say if a seizure starts with some fidgeting movement of the hand, some memory loss, that itself tells that temporal lobe might be at fault. If there is some abnormal sensations, some Jacksonian march where sensation moves from one part of the body to another, that will tell you that it might be arising from the parietal lobe. If there are bizarre, jerking, chaotic pelvic thrust or movements of the bodies to start with, though it moves on to have generalized seizures later on during the progression of seizure, but the initial findings would itself tell you that the seizure might be coming from the frontal lobe. If they have some problems with the eye, like vision problems, and then that culminates in the seizure, that will tell you that it might be coming from the occipital lobe. So depending on which area of the brain it starts, it's very important that you classify it as a focal seizure when you have that thing in the history. Next, please. So knowing a background of what seizure is and what epilepsy is and the kind of epilepsy, this is a very basic slide. You all know that approach to a patient with seizure, history is the key. We emphasize on history, history, history. Don't ever go near EEG. Seizure identification. So history is the key in identifying whether it's an epileptic seizure or not. I don't know how much you see non-epileptic seizures in Kolkata, but here the amount of non-epileptic seizures are quite high. Almost 50% of the patients should have non-epileptic seizures. So we focus on history a lot. But is history reliable? If you look at this study, which tried to identify seizure based on the clinical description in diagnosed temporal lobe epilepsy, they found that the history was very sensitive. Having said that, what it means is, if you look at if you just listen to the history, you would be diagnosing every little abnormal movement as epilepsy. But the specificity is significantly low. That does mean that if you rely on history, then you will miss the true epilepsy, but you will overdiagnose epilepsy. So what is the best evidence? The best evidence is the video of the episode, not the EEG. Because if you have the video, then video will tell you how it all started, how it progressed, how was the patient during those time. And to a neurologist's eyes, video can be more informative than having EEG. So we do not emphasize on EEG. What we do is we want a video evidence. Unless until patient comes within video evidence, we tend not to start on any antiepileptics. Yes, there can be situations, exceptions, where patients presents with a very clear descriptions of what happened, and that might be suggestive of either one of the epilepsy or or epilepsy syndrome. That's when you can be tempted to do EEG before you go on to start the medication. Next, please. You all know about these slides, looking into past history, developmental date, any learning behavioral difficulties, family histories are quite important. Please, next. Next. Again, examination is important, and particularly emphasizing on head circumference, any dysmorphic features to rule out any neurometabolic, neurogenetic conditions, neurocutaneous stigmata, especially looking for tuberous sclerosis, scaphoid spots, hypomelanosis of Ito, these things, and developmental milestones. The patients who are developmentally delayed would have high chances of having epilepsy. Not only developmental delayed patient, but the patients with ADHD and autism can have high chances of having epilepsy in the life. Next, please. I think we'll not run through the scenario. Let's move on, please. Next one. Next one. Next one. Next one. Next one. Next one, please. Sorry, I could not load my own slides, which is all of these slides modified. So I had to send slides to next one, please. Next. You can move on to the next slide after just next. Okay, yeah, so this one. So not everything looks like a seizure. It's also important to keep an eye on what it could be, because when a patient comes in and if you say that this doesn't look like seizure, or this doesn't fit into epilepsy, you need to tell them what it looks like, because they're not going to leave your office with the finding that this is not epilepsy. Many of them would, but it's always a good practice that you know what it's not seizure, and if it is not the seizure, then what it is. Yeah, next slide, please. So I've left the rest of the epilepsies and itch syndromes and itch types maybe for the next discussion, because those are itself a very exhaustive topic. Let's move on to status epilepticus. As you know, status epilepticus, previously we used to say that it's people used to wait till the child is having seizures for 30 minutes. Next slide. 30 minutes. And that was based on this study done in 1973, which showed that only after an hour or 1.5 hours of seizure activity in baboons, they had irreversible brain damage. And that's when it was thought that let's put status epilepticus duration as 30 minutes. But that was also quite delayed for many of the clinicians. So they were looking for some more nearer treatment. So what they did is they put this arbitrary 5-minute activities as a seizure to classify it as a status epilepticus. So seizures lasting more than 5 minutes, either a continuous seizure or 2 or more discrete seizures between which there is no complete recovery of consciousness, to classify it as a status epilepticus. Next slide, please. We'll come to next slide to tell you that why the 5-minute thing is there. So as you know, convulsive status epilepticus is very common in the pediatric age group, especially in a less than 1 year age group to 1 to 4 years. Pediatric population is quite common. As you grow older, the incidence of status epilepticus reduces by 10-15 years of age before again going up in the adult age group. Next slide. So to define status epilepticus and bring it down to a discrete definitions, there were 2 tasks in front of ILAE. That why 5 minutes? So what they find out is the next slide, time point 1 and time point 2. Time point 1, next slide, please. Time point 1 is when a seizure is likely to be prolonged, leading to continuous seizure activity. So if you don't stop a seizure at time point 1, it's going to be prolonged after that, and it will be very difficult to stop it. And this is different for different seizure types. Like if somebody is having tonic-clonic status epilepticus, 5 minutes is the time given to that. If you leave it more than 5 minutes, it will be difficult to stop. Whereas in absence status epilepticus, we have some patients who are in absence status epilepticus for weeks and weeks. It doesn't matter whether you leave them for 10 to 15 minutes or half an hour or 1 hour, because that's not going to change anything, whatever medication you give. Time point 2 is when a seizure may cause long-term consequences that includes neuronal injury, death, or alteration in the network leading to further developmental delay. And that is, in basic terms, is it going to cause any damage to the brain? And that time scale for a status epilepticus is about 30 minutes. For others, it's quite longer than that. And that brought the definition of a status epilepticus as anything that lasts more than 5 minutes, on the assumption that if you don't stop it by that time, it's not going to be stopped on its own. And that's when all the treatment and medications jumps in at 5 minutes. Next slide, please. So for first 5 minutes, first aids, nothing is required because most of the seizure will stop by 2 to 3 minutes. If it has gone beyond 5 minutes, you'll have to do something. I mean, not exactly at 4 minutes, 59 seconds, but after 5 minutes, you'll have to do something. And that's when your medications and other support comes in. Next slide, please. Next slide, please. So how a status epilepticus progresses. First 5 to 10 minutes is impending phase where it's building up. If you don't treat it by 10 minutes, it goes into a phase which is called established phase, which lasts half an hour, and it can be really difficult to treat. If you have not get over on it in half an hour, then it becomes refractory, and then it can goes for quite longer duration after that. There are seizures which can be super refractory and has not responded even after 24 hours of anesthetic medications. And we'll talk in our next slides why a seizure becomes super refractory and why we need to treat it within 5 minutes. What's the logic behind it? Next slide, please. So if you look at this slide, what it shows that when somebody is having a status, their GABA receptors internalizes. It goes from the cell surface to the inside of the cell and wouldn't be available. And most of them, almost 98 to 99% of the GABA receptor internalizes and goes inside the cell and wouldn't be available for the benzodiazepines to work after 5 minutes. And that's the rationale behind giving this 5 minutes as a timeline to start the treatment. Next slide, please. So one of the factors is this internalization of GABA receptor, and then the glutamate receptor comes up on the surface, leading to further excitotoxicity. So this excitotoxicity phase of the internal milieu of the brain is then followed by extracellular ionic environmental change. Then comes the energy failure, mitochondria fails, energy failure, and then the cell has no internal resources available to control the seizure. And the ongoing inflammatory process contributes to that. And this cascade of events leads to seizures becoming refractory and super refractory if you don't act within 5 minutes or first half an hour. Next slide, please. Next. So after the basics of basic control of the seizures, initially what comes is reduce the worsening excitotoxicity, and then the seizure becomes, if seizure becomes super refractory, then the aim is to have a neuroprotection. And that's when your all ventilations and anesthetic drugs comes into the effect. When you're dealing with a status epilepticus, it's very important to keep systemic complications in the mind. I'm not going into the protocol of status epilepticus treatment because I know you have your own protocol and every country has their own protocol. We have our own where we use 2 doses of benzodiazepines followed by levetiracetam. We have reduced, we have taken away phenobarbital. So we go for Keppra. Because it has been found as a very effective and safe than phenytoin. Do you still use phenytoin as a status epilepticus medication in India?
Yes.
Okay. So this protocol varies from country to country. The US, I think they are still using phenytoin. But the whole idea of this slide is to say that initial steps would reduce the excitotoxicity, and in super refractory status epilepticus, we move towards neuroprotections by ventilating the child and using different anesthetic medications. At the same time, please keep an eye on the systemic complications because that can be equally detrimental as like seizures. Next slide, next please. So when it comes to complications, you all know metabolic acidosis, electrolyte imbalance is quite common. With the aspirations, they can develop aspiration pneumonia whilst they're sieging, can lead to hypoxic damage. With the seizures, they can have muscle breakdown leading to myoglobinuria, impaired renal functions. Hypotension can be the effect of seizure itself, along with some coma-inducing drug that we use in super refractory status epilepticus. Pentobarbital that we use in our ICU can cause infections, and it can all lead to DIC. Next, please. So how to minimize it? How to minimize all this? The whole idea of treating a status epilepticus is to minimize these things as well as control the seizures first. Next, please. So what has been found most effective in reducing the progression of a status epilepticus as well as its complications is timely intervention and use of rescue plan for each and every patient. This study showed that after the start of a status epilepticus, it took almost 28 minutes to give the first dose of the medications and 40 minutes to give the second dose. And that's when the rescue plan came into effect. And now what we are doing, we are any patients who has got seizures more than 5 minutes in durations, they are sent home on a discharge plan with the medications that parents can administer themselves at home. And this we mostly use buccal midazolam, but sometimes we use rectal paraldehyde as well. There are different age dose range for different age groups, which I'm not touching upon. I'm pretty sure in India we give, and in Kolkata we give some sort of this rescue medications. When I was there, we used rectal diazepam. That's still used in UK by ambulance crew. Next, please. Next. So there are three kinds of status epilepticus. One is a quite common that we all see, generalized tonic-clonic or simple kind of seizures coming in with convulsive status epilepticus. The other one is non-convulsive status epilepticus, where they might have typical or atypical absences, and that's lasting for ages. What I want to emphasize is this third type one, which is a non-epileptic disorder, not the psychogenic or dissociative seizures, but the non-epileptic seizures where you would have acutely raised intracranial pressures and incipient tentorial herniations. These patients basically presents like acutely unwell child with encephalopathic features and repetitive extensor spasms. And here it looks like status epilepticus, but always think of tentorial herniation, and the scanning can really be life-saving in these situations. Status dystonicus is the one which can be confused with status epilepticus. So these are the two things I want the trainees to keep in mind when they're dealing with status epilepticus, that not all status epilepticus are status epilepticus. They can be status dystonicus, or they can be tentorial herniations in an acutely unwell child with encephalopathic features. Next slide, please. So, you all know how to treat seizures and status epilepticus. What I want to go on and talk is what you do if the seizure persists after further 20 minutes and when it has become refractory. Of course, you will seek help from the PICU if there is any. And there are a couple of medications that we use. One is IV midazolam infusions. There's another one, IV thiopental and pentobarbital. We have IV propofol and IV ketamine. What is more important is it also needs continuous seizure monitoring. Out of these medications, next, thiopental and propofol, the study has been limited, though there are some randomized control trial, but quite an insignificant number of studies. That's why these are not used as often. And there are concerns about side effects of these medications. Next, please. What we use is a midazolam infusion. I still remember I used to use midazolam infusion when I was MD trainee in ICH. It has got very excellent clinical seizure suppression rate of 76%, and it suppresses seizure within 41 minutes. What is more interesting to see about midazolam is you can use it with simultaneous EEG monitoring or without simultaneous EEG monitoring. When the simultaneous EEG monitoring was used to see the seizure control, it was found that it took longer to have the seizure control, as well as the mean dose requirement was quite high. It was 10.7 microgram per kg per minute. But if you don't use EEG, if you just want to see the clinical seizure suppression, you would see it controls within a short time and requires less dose. And there was a lesson from it. The lesson is, if you rely on clinical description, if you rely on clinical suppression of seizures, you might have suppressed the clinical seizures, but in refractory seizures, there happens something called electromechanical dissociation, where child is still seizing, still having electrical activity, but you are not seeing the outward manifestations of that in the form of clinical description of the seizures. So that's why there is importance of having a continuous EEG monitoring when a child has gone into refractory or super refractory status epilepticus. Because what we want to achieve is a burst suppression on EEG that will tell you that the seizures are going to be controlled and this child is not going to have seizures. Because even if you have controlled clinical seizures, the electromechanical dissociation and having persistent electrical seizures might impair and cause further neuronal injury, leading to further neurodevelopmental worse prognosis. But again, this all depends on the local logistics. Facilities of continuous EEG monitoring is not that rampant available. Next, please. If midazolam fails, then barbiturate infusion helps. This brings us to subtle generalized status epilepticus, and that's where we are in refractory epilepsy. We have already discussed that this is the consequences of prolonged generalized tonic-clonic seizures, where you have electromechanical dissociation. How do you know there's a seizure going on? And so what happens? You would have no clinical seizures in the patient, but what you will see is there's a major cardiorespiratory and autonomic features. You might see alterations in pupils diameter. You might see still patient is having high heart rate, but there's no clinical seizures. So physiological decompensation happen because of this ongoing electrical activities in the brain, and that will tell you there's something wrong. If you put on EEG lead, you will find electrical seizures ongoing. And this is where they need anesthetic medications, inhalant anesthetic medications. Next, please. Next. There are some special considerations. Previous slides. Don't forget, there was something in the next slide. That's okay. Don't forget pyridoxine. If a child is going into refractory seizures, that can be helpful. Midazolam elimination half-life is very small, 2 hours. So there is a high risk of recurrence, and that's why there's a role of midazolam infusion. Lorazepam is quite longer acting. As I said, we have moved out from phenytoin. We no longer use phenytoin except in exceptional circumstances. And the good thing about all the first-line IV drugs are they can be used through intraosseous needle if we struggle for the intravenous line. Next, please. Next. I wouldn't take much time on non-convulsive status epilepticus. What I want to say is that non-convulsive status epilepticus are there. I have 2 patients who are in absence status, and when they come in, they stay admitted for 7-10 days because they're in the status all the time. They are quite absent, dazed. Only thing to make sure that they it can be the consequences of both unexplained acute coma and can be the complication of acute neurological insult. So these two things needs to be ruled out by having a scan if they present first time. Next, please. Yeah, I just want to touch base upon when, because we're talking about non-convulsive status epilepticus, there are certain conditions which in which the patients can present with electrical activity whilst they are sleeping, and these are Lennox-Gastaut, West syndrome, Landau-Kleffner, CSWS, and Dravet syndrome. So these patients can go into non-convulsive status epilepticus. They can be in their own world, having electrical seizures ongoing for days and days. What is important is if you give carbamazepine, say if this patient is already on 1 or 2 medications and you want to control it, and if you give carbamazepine, phenytoin, or phenobarbital, it may exaggerate their seizures. What's important in this situation is the use of oral diazepines such as clobazam or steroids or salthiam or ethosuximide. That really helps when these patients go into non-convulsive status epilepticus. Next, please. Next. 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 Okay. So how long you will monitor? It says after a single unprovoked seizure, 80 to 90% of those who suffer second seizure do so within 2 years. So we monitor them for 2 years. Next, please. If a child has a seizure, first seizure at 2 years of age and second at 14 years, would we call it epilepsy? Next, please. No, because it's resolved. Those who have remained seizure-free for last 10 years with no seizure medicine for the past 5 years, they are said to not to have epilepsy anymore. Or the individuals who had an age-dependent epilepsy syndrome, such as childhood absence epilepsy, at 15 years of age, we can't call them that they had epilepsy anymore. So these are the two things to keep in mind when to say that they don't have epilepsy anymore. It's not only the 2 years, but these things. Next, please. Can you skip all febrile seizure slides? Because you all are expert on febrile seizures. Keep going, please. So I couldn't post my own slides. That's why this is happening. So coming, my last few slides would be on EEG. How sensitive and specific it is. Next, please. Next. So you could see EEG can pick abnormality truly in 60% cases and it miss in 40% cases. So EEG is not that specific. And it can pick abnormality in up to 5 to 25% cases when in reality they are normal. So it's not that helpful. Next. About 2 to 3% of the people who have interictal abnormality, if you put them on EEG, they in EEG they would never have symptoms. And also there are people who are in the community. If you put them, normal people, if you put them under EEG, they would have something come up on the EEG, which will put us in trouble. So what, again, this takes me to our basic slides, that history and video is the key. Next one, please. Next. Misdiagnosis is very common. And misdiagnosis, one of the reasons of misdiagnosis is relying on EEG itself. Next. So EEG is not the gold standard test. You can skip. You can next, please. Next. Yeah. So EEG is not the gold standard test. What it does is it just confirms the type of your epilepsy. So the golden rule is good clinical history and description of event. I think I'll stop here. Sorry for these glitches in the slides. Had it been my own slides, there wouldn't have been that much of glitches. And I did not cover the specific epilepsies because I think that's completely a different discussion. if you go into each and specific types of epilepsy. So I just wanted to touch base upon the overview of epilepsy and then some information about its status epilepticus and super refractory ones.
Thank you, Birendra, for your nice presentations. It was an excellent presentation, and you really have improved over the years. And I have seen Birendra as my PGT the day he first came, and what I'm saying now, and the way he speaks, where he presents, is an excellent one. I must thank Alpheus for sponsoring these sessions, especially the Verostate, the Phytonail, and I don't know about the starter product. We don't use much Lactosamide. And thank you, the postgraduate, for coming here. And thank you, Birendra. We'll see you again.
Thank you.
very soon. Thank you.
Thank you. Thank you.
Birendra,
Thank you. Hard leave now.
ভিডিওটা অন করো বীরেন্দ্র, ভিডিওটা অন করো তোমার।
আচ্ছা, ভিডিও ছিল না নাকি?
না, তোমার ভিডিওটা অন করো, তোমাকে আবার দেখতে চাইছে সবাই।
ও আচ্ছা আচ্ছা, আমি ভাবলাম ভিডিও আছে, জানি না। I can see you all. Shuman, Birendra sir, I can't see anybody behind Birendra sir. Thank you. Really feeling great to see you all faces. One day I'll come to this seminar room again.